today's talk is with
Morning.
Dr. Stephanie Blank. The topic is the next chapter, individualized surveillance and shared care. So the description is join us as Dr. Blank shares with the woman-to-woman community an informative talk on gynecologic cancer surveillance protocols, offering clarity on what patients and families can expect after treatment. She will emphasize evidence-based guidelines while highlighting the importance of individualized care, shared decision-making, and communication between patient and their care teams. Dr. Splank's discussion will help demystify follow-up schedules, tests, and the rationale behind evolving surveillance recommendations, empowering survivors to feel informed and supported in their ongoing care. Dr. Stephanie Blank is the Director of Gynecologic Oncology for the Mount Sinai Health System and is professor in the Department of Obstetrics, Gynecology, and Reproductive Science at the Icahn School of Medicine at Mount Sinai. So, Dr. Blank, we are so thrilled to have you. Thank you so much. I'm going to just make you, I think you can probably share, but just in case not the co-host, you can. There we
I
go.
will share.
Thank you.
Can you see that?
Yes.
Okay. Thank you. Thank you so much. Thank you all for being here. I love speaking to this group. So every time Jillian asked me, she's like, would you consider speaking? And I was like, of course. I'd love to speak. I put together this talk and then I just heard what Jillian said I'd speak about. So some of it's not there. I'm going to stop where I think it goes to the wrong place. And I just realized also I'd like to speak about something that I didn't put in this talk. So I'll probably stop at a certain point and kind of go off script if that's okay. Anyway, we'll just go there. And I'd like to leave some time for questions as well. So anyway, I made this title, but I'll just keep going. You don't need to hear me. Just kind of anyway. Nice to see you all. Let's just see. Okay. My disclosures, I don't have personal disclosures. We do research and the institution gets some funds from that. And I'm not going to be discussing any off-label use of drugs, nor will I be discussing any drugs at all. What will we be speaking about? We'll be speaking about what is surveillance, and we'll be thinking about surveillance by condition and some general concepts. And we probably won't be talking about platinum resistance. I probably won't talk about that. So I want to just distinguish survivorship from surveillance because sometimes they're kind of confused. So survivorship is basically the health and life. I'm going to read this to you. Sorry. It's the health and life of a person with cancer post-treatment and onwards. And it's sort of like all of the issues about this, sort of beyond the diagnosis and treatment, sort of like physical, psychosocial, and economic issues, everything else you're dealing with. And it's about getting the healthcare and follow-up based on your treatment, late effects of treatments, secondary cancers, and quality of life. And it's actually also involves your family, friends, caregivers. It's all of that. And so the day you get a cancer diagnosis, you're a survivor. So it's basically from the day you have cancer ongoing. And there's all this stuff about survivorship plans and all of that. But we're really going to be speaking today. Surveillance is part of survivorship, but we're really going to be speaking only about, well, it's not truly, but I'm really trying to focus on surveillance because Jillian said that would be a good thing for people to hear about. So surveillance in medicine, it's literally closely watching a person's condition, but not treating it unless there are changes in test results. So it's also used to find early signs that something has come back, and it's going to be used also for somebody who has an increased risk of disease. And so surveillance can be certain exams and tests that can be done on a regular schedule. But anyway, sometimes people are looking too hard. I don't know. Can you see my thing? Sometimes people are looking too hard and sometimes they're not looking hard enough. So like that's where we are, and we want to figure out the right balance, hopefully somewhere in the middle. There are problems with both of these, and I think the strategies are somewhat mystifying for people because some doctors do it one way, some doctors do it another way. And so today, my goal is to sort of talk about evidence-based ways to do this. Okay. So surveillance really is ongoing monitoring of individuals with cancer who've ever had cancer. And the goal really is clinical and cost-effective practices to detect recurrence and impact survival outcomes. That's important, survival outcomes, and I'll explain that in a second. And it's generally consists of checkups, tests, and screenings. And you want to have, again, improved survival and improved quality of life. Those are both really, really important. Okay. And I'll talk about this a little bit more. So, evidence-based, what does evidence-based mean? You always hear about evidence-based medicine. So, what this means is that this is based on studies. You could check scans every month and you might find things, but is this going to make people live better or live longer? Not necessarily. And I'll speak about that shortly. So these are the main bodies upon which the data that I'm going to speak about is based. So the National Comprehensive Cancer Network, you always hear about NCCN. What is that? That is people from all of the comprehensive cancer settings getting to get comprehensive cancer centers getting together and coming up with the guidelines. These are the guidelines upon which all of your treatments are based. This is how your insurance companies determine what they're going to pay for. But these are also the bodies of, and it's not only based on economics. I just want to be clear on this, but this is the best practice. When you hear about guideline-based care, this is the body that makes things up. These are who determines the best form of surveillance. The Society of Gynecologic Oncology, this is the grand pumbas of gynecologic oncology, the European Society of Medical Oncology, the American Society of Clinical Oncology. These are all like the great minds in the field. These are the people that are determining the surveillance guidelines. So in general, all of these people, they focus on history and physical mostly, not on routine imaging, not on routine tumor markers. I'll speak about that in 1 second. And the frequency really depends on cancer type and time since treatment. But if, as you're going to hear it in a second, the cancer type it's pretty consistent across them. Now, tumor markers are mostly applicable to ovarian cancer. And you're going to say, wait a minute, I have ovarian cancer, I get my tumor markers checked. So, the evidence there is something that we actually ignore. So I'm always holier than thou about, evidence. But with the tumor markers, there was a large study done in Europe prior to this century where they looked at women with ovarian cancer, and they followed them. They followed some of them with CA-125 and some of them just with symptoms. And they found that using the marker didn't help at all in picking up. They could find recurrences a little bit earlier, but it didn't help people live any longer. So they determined that you didn't really need CA-125. And in a minute, you'll just see that the evidence-based guidelines say you don't have to do CA-125s, but nobody in this country does not do CA-125s, and it's not acceptable to people in this country. So what people in this country say is that study was done in Europe. So, we don't believe it. But I think some people find the CA-125 extremely stressful and don't want to look at it, and that is acceptable. But so these guidelines say you don't have to do tumor markers because the evidence does not support it. I think that with the CA-125, we never make a treatment decision based solely on a CA-125. We usually use it to get imaging. So I don't think that there's necessarily an issue with that, but the evidence does not support it, just to speak to that. So what are most of the things that I'm going to mention to you are based on this paper of all those other groups. Everything else has people that are not just solely focused on gynecologic cancers. The Gynecologic Cancer Group has these guidelines specifically for treatment surveillance for people with gynecologic cancers. This is from 2017. Another one is coming out very soon, so there's going to be something updated. I will say there may be changes, and part of the reason why there may be changes is because now we use a lot more maintenance therapy. So a lot of this surveillance is based on the fact that people aren't necessarily on treatment, and if you're not on treatment, maybe you don't necessarily scan as much. But if you're giving somebody a medication that does have side effects, maybe you're going to scan a little bit more. So I might have to update you on this. But this is right now when I'm talking about surveillance, I'm talking about when you don't have anything going on. Maybe you don't have any cancer at all. And I'm going to speak after I speak about that, about when you do have something going on. So right now I'm speaking about, let's say you don't have any cancer going on at all for surveillance, just for these next couple of slides. So for surveillance in general, more is not better. You don't want to have unnecessary testing because it leads to more testing, some of which is invasive. And there can be great psychological toll. People waiting for their scan results having things in, there that are wrong or refer to things that they say were already there and they didn't know they were already there. And early detection is earlier treatment. Less time off of treatment is not necessarily shown to improve survival. So it's not necessarily better to find things earlier here. That's been shown that it's not necessarily better. So for ovarian cancer surveillance, the frequency of follow-up depends on how far you are from completion of your primary treatment. In the first 2 years, every 3 to 4 months, year 2 to 3, 4 to 6 months, year 3 to 5, every 6 months, and after 5 years, it's yearly. No pap test. It's funny, we used to do pap tests very regularly as follow-up. There's no reason for that. CA-125, it says optional. You don't do imaging regularly. And then if you suspect recurrence, you do scans and you do CA-125. So this is going to be basically the theme as we look at all of the other follow-up. So for endometrial cancer, similarly, your rate of follow-up depends on whether you have low risk or high risk disease. And you basically, for the first couple of years, it's closer in time. And then as you get further out, it's further yearly after 5 years. And same thing, CA-125, there are certain types of endometrial cancer that are associated with an elevated CA-125, and those it is reasonable to follow a CA-125. And same thing with recurrence, you can check scans on a CA-125. And then with cervical, vulvar, and vaginal cancer, here, however, you do include PAPs in your follow-up. That's the difference here. So what surveillance is not is routine scans just to be sure, or routine scans every 3 months forever. And why is that? And first of all, I mean, if you're in the business of giving chemo, aren't you going to look for more reasons to give chemo? So you have to think, sorry about that. But I mean, I don't mean to sound cynical, but that's one reason. I think sometimes people want scans to know that everything's fine. But that's not necessary. First of all, there are, it's just, you're going to find things that may be things that you don't need to see or want to see, or may lead again to more testing. If you need scans, great, you should get scans. If you don't need scans, you are building up your exposure to radiation. And so it's not something that you want to do. In the course of somebody's life with cancer, they're getting enough scans that they need. I don't think you should get additional scans that you don't need. I don't want to scare anybody there. That's not my point. But I think getting scans just to get scans is not really a good idea. But if you have something going on, symptoms, it is really important to report them. All these symptoms are things that people have. So how do you know if something's real or not? I'll go through the symptoms first. So symptoms to be, to look out for are bloating, pain, bleeding, fatigue, weight or bowel bladder changes. You want to report them early because most recurrences are symptom detected. That's really the way that most things are found. They're not really found usually on a scan or on a CA-125. And symptoms merit imaging and further workup. That's when you do get your scans. You're going to have these symptoms and you're not going to have a recurrence. So if you have a bloating for a day and it goes away, that's not a recurrence. If you have bloating for 2 weeks and it's not going away, that's when you need to report it. If something's just not right for 2 weeks, it's worth discussing with your oncologist. And then you do get imaging and you do get further workup. But your visits are the main part of your of your surveillance. So what happens at those visits? You have a symptom review with your doctor. They will be asking you questions. They will be looking at you, assessing you. It might not seem like they're doing much, but they are. They're doing a focused exam. They will be doing imaging or labs if indicated, and they're checking into your lifestyle and emotional well-being, and they're having discussion. Um, so this is going to seem self-serving, but it's not. This is just it's going to seem very self-serving, but this is my advice for the visit. Okay. I would say you should go when you're not pressed for time. There's always a delay. You may need a study afterwards. There might be something like that. You want to stay calm. You don't want to have your doctor walk in while you're already angry that you've been waiting or you're feeling rushed to get somewhere else. A lot of people have just a reaction to being at the place where they are because it's a place they associate with um, having had chemo or cancer or something like that. It can be a very stressful place to be. I tell people to bring a book, just do something for distracting you from being at that place. Um, I recommend that people bring a list of questions and use that list because oftentimes you get kind of flustered when somebody walks in. So I do recommend bringing a list of questions so you don't forget to ask the things that you want to ask. If you know you're going to have a complex discussion, it's not a bad idea to bring another pair of ears or a note taker. And then you can have your visit. And I do think it's important to make sure you understand your current condition and the next steps if there are things going on. So, am I free of disease now? How am I doing? When do I need to be seen next? If it's something where you think, you're going to need another scan, when do I need my next scan? When do I need just sort of make sure you understand what the next steps are. And then if there are things being ordered, how am I going to get those results? With portals now, I think you all know this, but it's a law, things get released and you may get them before, your team has the opportunity to convey them to you. Do you want to see them? Do you not want to see them? You cannot open them. You need to sort of have a discussion with the person how that's going to happen. The CA-125s, if you get them, will come to you before your team gets to talk with you about them. It's a good idea to sort of understand that. If you're working with a practice and sometimes you need to understand how communication works with the practice, that can be tricky. Sometimes doctors never, like in my practice, I never get a message unless somebody, it depends on how things go. It's a good idea to sort of understand how that happens. I think that there are a lot of things like that. If you feel very important that you want to discuss something with your doctor, tell your doctor that so that they know that. I think that there's just a lot of nuances to things. I think that's kind of a good thing to know. In terms of things like telehealth and not, at present, telehealth is covered. I think it can be a very good means for some certain discussions. Like if you don't need a physical exam, it can be a good thing. If you don't like it, just say you don't like it. If you do like it, you like it. You have a lot of say here. I think it's important to just sort of remember that. It's important that you feel listened to and that you have good communication. It can be stressful, but it's real. Oh, I'm going to talk about communication in a second here. We'll do that. So shared decision making. In the past, the doctor just said, this is what you have, this is what we're doing. It was a very paternalistic way of decision making. There was no patient communication. Now, and then there's informed medical decision making is when the doctor just gives the patient all the information and says, here, you make a decision. I don't think that works as well either. I think a shared decision making is really the best way, where the doctor gives the information to the patient along with recommendations. This is what's going on. This is what I think. The patient also says, okay, this is what is important to me. And together you make a decision together. It sounds very basic, but it's not. It really requires two-way communication. And it has been shown really to improve, patient, um, you know, being happy with their care, satisfaction, patient satisfaction, and patients actually have better psychosocial and in some case physical outcomes. It's really important, and it all just speaks to listening. You really need to know that you are listened to. If you don't feel like you're listened to, and I'm not saying that I listen. This is not like, this is just saying, if you feel you're not listened to, you either need to say, I need to be listened to. I need more time. I mean, time is a real situation. At doctor's offices, people are booked in it's not under the doctor's control how they're booked. If you don't have enough time, ask for more time. You might need another appointment. You might need two appointments. So that's a real issue and a real thing. Sorry to say that, but being heard is extremely important. If you don't feel you're being heard, ask for more time. The next thing I wanted to talk about in terms of surveillance, which I think is really important, important to understand and important to know about, is circulating tumor DNA. So I think I want to talk about this for a little bit because this is newer. It's not yet proven. It will probably be proven soon, but I wanted to sort of explain what it is, how you do it, and what you do with it. So circulating tumor DNA is a biomarker. So basically, to get it done, you need some tumor. The tumor is sent to the lab, and from that, they make a probe, and then they check your blood. And generally, it's done quarterly, and they look for fragments of the tumor in your blood. Lots of times they can't find it. If there's nothing going on, it'll be zero, but then they might find it, and they basically graph it over time. Right now, it's approved in ovarian cancer. And I don't think it's yet approved in the other cancers. However, the company is covering it now. I have no commercial anything with the company. It's just a fact. So it's being covered. So right now there's not patient cost for this. So the tricky thing is they need to have enough tumor for this. If your tumor that you ever had was from a long time ago, it can be tricky to get. It's probably still available somewhere, but it's good in some ways. I'll tell you right now, it's more prognostic than anything. Alone, it does not diagnose a recurrence, but if you did have, you were known to have nothing going on and then it does bump, what would happen is that you would get more imaging to find something. Now, everything I've said has said, why would you necessarily want to find something earlier? It doesn't necessarily lead to something better. This is still being looked at. This is like the newest thing. I will say that in some situations, finding something earlier may have benefit. If you haven't had something for a very, very long time, it could be something that could be managed surgically versus not. That's sort of the biggest thing. Or it could be something that could be treated before symptoms developed if you haven't had something for a long, long time. That's some of the things. So with this, what are the advantages
Dr.
and
Blank, can I interrupt you for one sec?
please
Someone
do.
in the chat
Oh,
wrote,
thank
"What
you.
is a long time?"
Oh, years, I would say. More than 6-9 months, I would say. If you have a CA-125 that's very sensitive, you may not need this. This is very useful in a couple situations. I would say this is very useful in cervical cancer, where imaging is very hard to interpret, where somebody's had radiation. This can be very useful in situations like where somebody is on immunotherapy, where you take it for a very long time and it's very hard to know when to stop and be okay. That's a very useful time for this. it can be very useful in a situation where somebody has had um, a certain course of treatment and you need to stop at a certain point in time and you think
Oh.
you're done, you don't know if you're done. There are certain situations where this can be very useful. We're still really learning a lot about this, and if you have questions about this, it's worth discussing with your doctor. I think we're still learning about this and learning the best times to use it. It is a double-edged sword again because it can cause stress. One value means nothing. It's something again you follow over time. It's another biomarker. I think with ovarian cancer, it may be something good for people that do not have a CA-125 that's very helpful. It's known to be prognostic in ovarian cancer for people right after they finish their chemotherapy. So we're really learning a bit more about this. It's fairly new. It's used a lot in other cancers right now. For example, in colon cancer, it's used to help with treatment decisions. Right now, for our cancers, it's not used for treatment decisions. Does anyone have questions about this? Because this is a very hot topic, and I'm sure people have questions about this.
There's
Um,
one question in the chat, and I also see Marlene just put her hand
yeah,
up.
yeah, yeah,
The
please.
question in the chat is from Catherine, and she wrote, "Is the circulating tumor DNA test done automatically?"
No, no. It's fairly new. It requires if your surgery was not in the past year, it requires going back to the pathology department, and getting you need the old tumor. I've had several situations where we've tried to do this and the tumor, they couldn't make the probe. So sometimes you can't have this. I have never had a situation where we did a biopsy just to do this, I will say. So I don't know if the risk of doing like the sort of the going through with a biopsy just to get the tumor to do a probe is sort of risk benefit is worth it there. It might be worth discussing if it's very important to you. If you need a biopsy to get some tissue to do some sequencing of your tumor, it might be worthwhile, getting a little extra tumor to do this at the same time. I wouldn't necessarily do a biopsy just to do this, but that's something you might want to discuss. So this is just another piece of things, I would say.
Um, Marlene, your hand is up. Is it okay if we ask some
Yes,
questions?
I'd like to answer questions about this. But this I was like, oh my gosh, people probably want to hear about, and I don't know everything about it. I apologize, but please ask questions about this.
Okay, Doctor, I have to start with one thing. I've been listening to this and making notes, and
Hello?
you repeated something a couple of times, which is finding out something earlier is not necessarily beneficial.
Shingles?
This is pretty much
Oh,
this is pretty much contrary to what we've heard from all sorts of sources over the years, that
Yes,
it's better to have something described. And also, you talk. I have to bring this up, and I'm very hesitant to bring it up.
I please
Have
do, please do. I won't be
well,
offended or anything.
I have yet to meet a doctor and follow up for cancer doing any of the things that you suggested, and they certainly do not have the with the exception of a radiation oncologist, there has not been conversation. You're lucky if you get a question in, and you're even luckier if you get some, information that's going forward as whatever. And I don't know if this is the norm, but I think it's a function of the timing and whatever. But it is very difficult. I'm someone who always prepares for. I spend more time preparing for a doctor's meeting than is ever spent. And even today, when they're using AI to take notes, doctors are looking at a computer, with rare exception. There are obviously exceptions, but I find it extremely difficult to feel assured that today we're getting, in general, the level of care that we need when it comes to long-term follow-up. And I bring this up because I have had now, unfortunately, two friends who have died from many years later developing things from the cancer they had originally. And they had problems over the years, but the doctors sort of said, no, no, nothing's really going on. And then it came down to being diagnosed and having like 2 or 3 weeks to live. So I am listening to all of this, and especially
Yeah,
with talking about circulating tumor DNA. I guess, what I'd like to see is, and if you know about this and where we can look this up, if there really are protocols written down for post treatment by your type of cancer, because I have never had that kind of follow up from anybody. about I've had to ask for certain things along the way. And also I think Sherry might want to address this directly herself. She brought up the great question about the viability or the relevance or of a CA 125. I'm just feeling a real sense of, you're saying that a lot is, and again, this is just me taking this way. I'm not saying this is what you're saying. My feeling is that all the stuff we've been told is really it's not really necessary. And you were emphasizing that a lot of people get stressed. I will tell you that I have been more stressed by what hasn't been done in terms of follow up than anything that could have been done. So I'm concerned now, all these years later, that was I really getting what I needed when I needed it? And the more I hear about this, I'm like, well, you're an expert and you're the head of all of this, and if you're saying this, it kind of goes sort of against what some doctors have told us. So thank you for listening, and I really appreciate your going over all this. It's very helpful. Thank you.
No, that's great, Marlene. Hey, Jillian, do you want to make us like a big happy group?
I think then just stop screen sharing.
Yeah, me. I'm the one who could do that.
No,
Sorry.
that's okay. I thought
Yeah.
I would be able to, but
Yeah,
it's
yeah,
your
yeah.
end. Thank you. Yeah, this is better.
No, Marlene, I'm glad you
I'm
said
also
all
going
of
to
that.
stop
Yeah.
the recording then, because then I think then that way, if that's okay, it's just a little bit
Yeah.
easier to
Whatever you
people
want.
might feel more comfortable sharing like that. I prefer it.